Hey there, my name is Hannah Menarchik. I'm a senior biology student at Mount Aloysius College, and I can almost guarantee that breast cancer has either impacted you, a family member, or someone you know. Breast cancer is not discriminatory and affects us all. I had never dealt with breast cancer on such a personal level until my grandmother was diagnosed right after Christmas in 2021. She is cancer-free today. Although breast cancer is scary and it affects many people globally, researchers have been constantly trying to find ways to reduce your risk of developing breast cancer. So here I present a question to you. Do hormone replacement therapies increase the risk of developing breast cancer in postmenopausal women? A range of hormone replacement therapies are available for women to use to relieve menopausal symptoms. While hormone replacement therapy can bring several improvements to quality of life, concerns have arisen about adverse effects, particularly the increased risk of breast cancer. For some background, data was collected using a nested case control study and public electronic health records from the UK's two largest databases, Q Research and CPRD. Whew. The data was analyzed separately, and then the results were combined. In this study, women were age ranged from 50 to 79 years old and who received an initial diagnosis between 1998 and 2018. Those who were excluded from this study were those who already had a mastectomy or diagnosed with breast cancer before or after. Oral, subcutaneous, transdermal, and topical estrogen or progesterone medications were included in this study, as they are commonly used to treat symptoms of menopause. For all treatments, the reference category was no exposure or never users of hormone replacement therapies. The hormones in the study include estrogen, estrogen-progesterone combinations, and tibolone. Now that we have a better understanding of the study, let's take a look at this graph and interpret the data. Figure 7 uses a cohort study to determine breast cancer incident rate per 10,000 women. Women unexposed and exposed for different durations to different hormone replacement therapies were compared by age range. Rates were estimated using rates in unexposed populations multiplied by adjusted odd ratios derived from subgroup analyses for different age categories seen in a separate figure. The yellow bar represents past short-term use, the pink equals past long-term use, the blue equals recent short-term use, red equals recent long-term use, and purple is used for those who have never used hormone replacement therapy before. Overall, the results of the study show that 34% of women with a diagnosis of breast cancer and 31% of controls had used hormone replacement therapy prior to 1 year before their cancer diagnosis date. Compared with never use, in recent users with long-term use, estrogen-only therapy and combined estrogen-progesterone therapy were both associated with increased risks of breast cancer. With an adjusted odds ratio of 1.15, looking at a 95% confidence interval from 1.09 to 1.21, and 1.79, still looking at a 95% confidence interval of 1.73 to 1.85 respectively. These results are statistically significant. To be noted, it is clear that combination therapies in all categories and age ranges show the highest incident rate of breast cancer. Most hormone replacement drugs are associated with increased breast cancer risk, with the highest risk coming from longer duration of use and combination treatments. Small increases of breast cancer were found in estrogen-only therapies as well. Additionally, associations were more pronounced in older women, and findings report a decline in risk once hormone replacement therapy was ceased. The sample size of this study was huge, with 98,611 women diagnosed with breast cancer between 1998 and 2018, and they were compared to 457,498 female controls. I thought it was important to let you know that this study was consistent with previous studies. Additionally, like any other experiment, this one had its limitations. Some of the information lacked, such as some women's BMI weren't taken, their smoking status, their alcohol consumption, type of tumor they had, and the stage of cancer they were in. For future implications, it would be beneficial to know the tumor type, as associated risks between hormone replacement therapy and tumor types may differ. Additional experiments could also be done using animal models genetically predisposed to breast cancer to assess the effects of different hormone replacement therapy regimens on tumor development and progression. The bottom line is, if you're someone looking into hormone replacement therapies to help with your menopausal symptoms, talk to your doctor and do your own research to choose the best options for you. With enough research, I am hopeful that we can reduce mortality rates and find a cure for breast cancer.